Good morning, everyone. I woke up early this morning and I was looking more into the different types of iron and why we give certain types of iron versus others. So, I'm going to start out by talking about the different types of iron. Iron, elemental iron, for instance, which is typically oral iron that we give to patients who have iron deficiency. And then we also have iron salts, which are less reactive, less chance of hypersensitivity reaction than our other IV irons, such as iron dextran and ferriheme, which is iron oxide. So we call the iron salts, even though they're typically bound to polysaccharides, not because they're salts in a chemical sense, but because they have a similar behavior when placed in an aqueous solution. So pretty much iron salts dissolve in water and they also dissociate from their polysaccharide. Iron oxide and iron dextran do not do those things. So they also have a higher chance of reactivity, and that's why they're not classified as iron salts. So basically, pharmacologically, we call iron salts to help us categorize them, and also because of the way they behave in a solution as far as dissociation. Some patients, especially patients with chronic kidney disease, may not be able to take elemental iron by mouth, and they may not be able to absorb it very well. Iron is acidic in a solution, typically, when it dissociates from the polysaccharides in the IV iron, but iron in general, elemental iron, is acidic. And it also requires an acidic GI environment, stomach acidity, to be well absorbed. So patients with chronic kidney disease often have absorptive issues related to, number one, their body's lack of ability to activate vitamin D, which leads to hypocalcemia, which leads to a decrease in gastrin secretion. Also, uremic gastritis causes inflammation of the stomach in patients with chronic kidney disease, which further decreases their ability to have an acidic, well-absorptive environment for elemental iron. Patients also may be on medications like H2 blockers to help deal with that gastritis issue. Or any other symptoms, GI symptoms related to GERD. They may be on proton pump inhibitors, and they may also be diabetics. These H2 blockers can decrease the acidity of the stomach environment, of course, and so can the proton pump inhibitors. Also, patients with chronic kidney disease may be on phosphate binders, and they may also be avoiding potassium and sodium, which are acidic as well, that add to the acidic environment of the GI tract. Iron often causes GI symptoms, even when administered IV, because of the osmolality, drawing water into the bowel, and also because it's acidic and can irritate the GI tract. So those are some of the differences between the different types of iron, and a lot of times insurance determines which type of intravenous iron a patient is able to get. And also certain types of IV iron may be more sustained release, like iron dextran, which is also the more reactive chance of having a hypersensitivity reaction to that specific type of iron, as well as ferriheme that we typically titrate and break into different doses, or break the doses down to be able to give them not all at one time, basically. So that's a lot about iron.